Sammy, is your presentation on the computer?
It should be, yes. Sorry.
Oh, give me jump.
I swear it's at the top corner.
All right. That's good to have you present.
Sorry, I was really rushed.
Is it shared?
I don't know if it's video, so you
I'm just gonna do it. Sorry.
No, I am quite happy just to stand here and smile and let you do what needs to be done.
Great.
I will introduce you and say nice.
Oh, thank you. That's all I need.
We just hopefully. That's too far from the presentation when we realize it's
What about it?
Hi.
Thank you. Is it sharing? Yeah. I'll jump this not yet.
Oh, I'm sorry.
Thank you.
Do that.
Cherry. I was wondering, are you happy to use the QR code or the URL? Okay. Otherwise,
That's okay. I'm trying to do it online, but that might be together.
yeah. Yes. My understanding is just here. Is that okay with you?
Doing that into Sheree. Yes. Yes. Oh yeah, I was
Let me see now that you speak, it's still.
okay.
We will wait.
I just thought when you said this was presentation ready, I'm like, well, start now. Yes. Okay. No, this one doesn't work, but the lapel does. This one has to be put on charge.
So we're using the repel one for questions then.
Yeah, we can use the repeller for questions.
Oh, no questions is fine.
Oh, I've got a lot of questions. It's all going to be data questions for you.
I'll be like, we'll direct it to our data scientist.
Yeah.
Our stuff. They're like, I don't know, I made it up. I Googled my code. So I'm charging that. Like it's charged. You have battery.
I am like I've been told by my supervisor I'm really talking shit. So what am I got my PhD in it? So
It's, when I start, yes, because just things play in the background.
I already got in.
Yeah, sorry.
that's like just bougie.
Absolutely.
No. If you need me, message me. I need to make sure both things work.
I think so. I think most things should work. And either way, we're troubleshooting.
You haven't broken down your computer. You'll be fine.
Yeah, I'll be fine. So far.
You don't have to. But there's
For another 7 minutes. Yeah. Okay, everyone, we've got a few more minutes until
take
we
your
schedule
time,
2
keep
o'clock
talking.
start. So talk about yourself. Oh, yeah, great. Thanks. There's a little USB just. I'm okay to minimize that.
Minimize this one.
Yeah.
Sorry.
And you can breathe. I know. I think that should be fine. I'm checking the agenda. Sorry. Do you want to check?
Savvy.
I just click that. Fatal or fighting here yet? I'll just have a quick ask about this other. Yeah.
It's like moving to see monster, so.
Everyone's fine, we need that time.
That was a superb attendance to your study. It's good, isn't it? It's so fun.
No. It's the one with the previous one. And then. And
Yeah.
Yeah. Oh, yeah,
Yeah, you're on the national section.
If you go on YouTube, it's
Good afternoon, everyone. That brings us to 2 o'clock, which is our third short oral presentation session for this afternoon. Thank you very much for being here and for your interest in our presenters' presentations. So it's pretty tight this afternoon. If you went to the session earlier, it's 5 minutes presentation with about 5 minutes for questions. If you do have a question, please wait for me to bring the mic around. That way the questions can be heard by the powers that be in the computer world and recorded for posterity. So with no further ado, I'd like to introduce Dr. Sammy Isaac. So Sammy is a PhD candidate here at the University of Sydney, working towards becoming Dr. Sammy Isaac. And he's presenting his work, Conscientious Objection and Refusing Supply, Australian Pharmacist Perspectives. Thank you very much, Sam.
Thank you. Thanks for having me. So I'll get right into it. Just recently, a historic and far-reaching decision by the US Supreme Court officially reversed the Roe versus Wade legislation, revoking thousands of women's constitutional right to access to medical abortion. While back home in Australia, New South Wales became the 6th state to legalise voluntary assisted dying. These are just 2 of the many ever-changing ethical dilemmas faced by pharmacists in practice. And at the centre of this all is the rarely discussed notion of conscientious objection and its effects. So my name's Sammy Isaac, and I am a PhD candidate currently supervised by Professor Andrew McLaughlin and Associate Professor Betty Cha, and my research is Conscientious Objection, a survey of Australian pharmacists' perspectives. Now, the aim of our research project was to investigate pharmacists' decision-making in complex bioethical scenarios around the right to conscientious objection and explore reasons for their choices. We utilised a mixed methods approach and analysed the results from an online vignette-based questionnaire on scenarios related to medical termination, emergency contraception, IVF surrogacy, and voluntary assisted dying. Our particular sample size was 223 Australian pharmacists across the country, and on average, our demographics were 69% female, which mainly worked in a community pharmacy setting with an average age range of around 25 to 34 years of age, and a work experience average range of around 1 to 5 years. Our vignette cases included the following. One was the MS two-step medical aborticipant for the medical termination of a positive trisomy 21 fetus. 2, an emergency contraceptive pill for a consenting 15-year-old. 3, clomiphene IVF therapy for a surrogate for a same-sex couple. And 4, pentobarbital for voluntary assisted dying. Now, our results as displayed here indicated that the majority of pharmacists did agree for the supply of prescriptions across all 4 vignettes, as you can see in blue. Some of them did provide a conditional supply, and our research paper actually provided a comment section to allow to underpin the reasons why that was the case. And a minority chose not to supply at all, again providing reasons as to why. Our survey also had additional questions to try to find a correlation between other characteristics or factors, including religiosity and the notion of continuity of care. But just in the interest of time, I'll look at the correlation that was established between religiosity. Essentially, a strong self-reported religiosity by participants did have a statistically significant relationship with pharmacists who chose not to supply, particularly for cases 1 and 4 and a bit for 3. And these were the life and death scenarios, which was the aborticipant and voluntary assisted dying. We also did a thematic analysis where we analysed lots of the comments and responses provided by the participants. And I'll just highlight a few of them in each case. Case 1 was the aborticipant. And as you can see, 1 was quite passionate in stating they would not supply, unborn baby has features of life, mother can hear the heartbeats, it is murder, and we should not be forced to participate in such a crime. With the emergency contraceptive pill, it was more, I guess, shrouded in a misunderstanding of the legislation. A lot of the participants were choosing conditional supply. So 1 in particular was stating they would want to know the age of the boyfriend, was it consensual, before they even deemed it appropriate to supply in this instance. For case 3, the provision of the IVF therapy for a surrogate, majority of participants did support this and say they would supply. And to highlight that, 1 passionately said, why is this even a debate at all? Check that it's safe and supply the damn medicine. It's our job as pharmacists. If we wanted to play the religious card all day, we should work in a church. So quite passionate responses across the participants. And you can see the dichotomy in the response as well, but due to time, I'm unable to go through all of them. And the last case was voluntary assisted dying. This was quite emotional, as you can see some emotional responses which would lead towards not supplying. 1 I'll highlight is more of a conditional supply, stating that they need more training and guidance around the situation. So before supplying, I would want to undergo some extra training in this field, refer to a pharmacy that already provides the service. So essentially, with this thematic analysis, we were able to generate secondary drivers, which would further drive our primary drivers at the crux of our research. And that was the role of the pharmacist, ethical considerations, but something that was more undocumented was the notion of lack of training and guidance, particularly when it came to conscientious objection. So our study basically underpinned the undocumented perspectives on workplace challenges and a lack of guidance around conscientious objection in pharmacy. Our findings highlighted an absence in the clear, specific professional frameworks to guide pharmacists who choose to exercise conscientious objection. And this would further our future research in exploring ways to make these decision steps appropriately, keeping in mind equity of access and continuity of care. Thank you very much. I'd love to acknowledge my supervisors and our data scientists side.
Thank you very much, Sandra. I'll start if there's no further questions to start off. So I noticed that your demographic was predominantly female, which I guess is not unusual among pharmacists, but also young female. And your cases had a bit of a flavour around women's health. Do you think the nature of the scenarios could have influenced some of the responses that you saw? Yeah, absolutely. I feel like the nature of the scenarios in general that we're faced in healthcare a lot of the times do underpin women's health. Whether that's deliberate or not, it's just a factor of healthcare in general. And our sample size and demographics were a little bit difficult to control purely because the way we, I guess, enacted this particular methodology was through an online survey, and a lot of kind of younger, I guess, professionals are on Access Online. So that was one of the aspects that we had to take into consideration in our limitations. But I definitely agree, it shapes and I think is a good snippet of women's health perspective in their responses. Yeah.
I know you didn't test for this, and I apologise if you didn't cover it, but you didn't mention it. Do you have any feeling for what people will do after they deny supply? Like, would they say, look, I won't give it to you, but if you go down the street, they will, or I won't give it to you, and I suggest you don't ask anyone ever again, type of thing?
Yeah, we did. In the thematic analysis, there was actually quite a lot to underpin. Some responses said that outright, and I'm not sure if I can showcase one of them fairly. Where is it? I think one of them just said, I don't know if I've documented it here or not, but said they wouldn't at all, particularly for voluntary assisted dying, I think it was. And they said, I wouldn't. And if, oh no, it wasn't. It was here. If I found out it was a gay couple, I'd say I don't have it in stock. Try somewhere else. It's my religious belief that family needs to have a father and a mother, and I don't want any part of it. And they were quite transparent about it because it was anonymous, which we appreciated in a sense. It showcased, I guess, a true understanding, underpinning of what someone's personal beliefs were. But what we were able to cross-correlate is those who did indicate religiosity were those who were selecting do not supply. But additionally to that, there was also that kind of, I guess, notion that they weren't necessarily having to speak to any higher power when they were picking to conscientiously object. So I guess the issue here is everyone has a right to conscientious objection. That's within everyone's fair right. But in doing that, what are the risks associated with that when they do enact it? And I feel like in pharmacy particularly, we're always in the shadows. We don't have a voice to speak when it comes to these situations, yet we're the people responsible for a lot of these, I guess, medication supplies. And when it comes to it, we really need a framework that guides us in the decision-making. So if someone does choose to conscientiously object, what's the next step forward for them and their employer and the stakeholders in place? And we don't have that.
Thank you for a very interesting presentation. I just wondered, with respect to religiosity, did you find out which religion those pharmacists belonged to and which religion predominated where they would refuse to, supply the medication?
We didn't, and that was a deliberate choice due to just, I guess, discrimination, and we didn't want to pinpoint one religious group over another, particularly noting that our scope of our research I think was restricted with the notion of it being online and isn't a full representation of each demographic or sect of religion. In saying that though, there are some studies in the US which we were comparing when we were trying to do some of our literature review before developing this particular study, which did underpin religious groups. But it was ironic, I think it was in the US, one study was pinpointing different religions, but left out a huge chunk of other religions. So they were only looking at, I guess, Catholicism and then broke it down into Anglican and it was quite restrictive to Catholic, Islam, and didn't include any other religion. So it was quite, I guess, segregating, which I don't think is the case. Religiosity is quite fluid and spirituality is quite fluid. And I think someone doesn't necessarily have to belong to a religion to have religion influence their decision-making. That's okay.
Okay, I think we'll let Sammy go.
Thank
you very
you.
much.
Thanks so much.
Okay, so our next speaker this afternoon is Dr. Jack Collins. Jack's a practicing community pharmacist and a postdoctoral research associate again here at the University of Sydney. Could you please make Jack welcome for his presentation, developing and testing a novel method to explore implicit bias in community pharmacy. Thank you.
And thanks everyone for coming along. So in 5 minutes, I'm going to try and get through this. We'll see how we go. So for those of you who are familiar with what implicit bias is, the Cohen Institute in Ohio describes that as attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. These are activated involuntarily without awareness or intentional control. And these can be positive or negative, and everyone is susceptible. So if I was asked to ask you all to think of who a caregiver might be for a child, most of you think of a young woman. That's implicit bias. That's distinct from explicit bias, where I might have the attitude that I believe a woman's role is in the home. It's a little bit different. Okay, so there's a distinction. One happens like that, the other is an explicit attitude. So it's present in all aspects of society. We see it in the arts, the judicial system. So we think of some of the police shootings and things that have been happening in the United States in recent years, and in healthcare as well. It has been observed in demonstration in response to race, weight, gender, disability, among other patient characteristics. So it is known to affect communication in health. What we don't know is whether it affects patient outcomes. So there's definitely an interaction between patient-provider communication when implicit bias is present. Whether that leads to outcomes, we don't know. We haven't really looked at this in pharmacy, in practicing pharmacists, mostly been in students. So the aim of this study was to develop and pilot a novel method for exploring and reporting implicit racial bias of community pharmacists in their own practice setting, i.e. the community pharmacy, and to determine if there's any suggestion of implicit racial bias. So I just want to flag this is a feasibility study, so it's just a little hint. Please don't go running away saying that pharmacists are incredibly racist after this. So to do this, we looked at the most common racial backgrounds using Australian census data. So the most recent census data gave us East Asian, Middle Eastern, South Asian, and white. So we then hired 4 experienced actors to act as simulated patients. We recruited 8 community pharmacies in metropolitan Sydney, and Beck's here with me. We walked the city to find those pharmacies. And then we came up with 4 common women's health cases. So cystitis, emergency contraception, period pain, and vaginal thrush. We had hoped that the kind of uncomfortable nature of having to talk about this might elicit a little bit more implicit bias than something a bit more run-of-the-mill. So we had our actors wear sanitized dress, and they all spoke in a neutral Australian accent, and they visited all 8 pharmacies in a single day, every Thursday for 4 weeks at a similar time to maximize our chance of getting the same pharmacist each time. Each pharmacy only got each case once. We audio recorded those visits so that we could analyze them, and we also collected some quantitative data. So this is a mixed methods approach. I will be focusing on the qualitative data given the time constraint today. So after the actors went in and acted the scenario in a covert manner and came back out, I then did an interview with each actor immediately after using a standard semi-structured interview guide that were quite brief. And then we, of course, transcribed the interactions between the pharmacist and the pseudo patients and the interviews, and we did discourse analysis. So we had an experienced social scientist work with us on this. And so we did an analysis of the 2 transcripts, came up with discursive frames of abrupt, neutral, or caring. And then we went back through and recoded all those transcripts with those discursive frames in mind. So we could triangulate what we heard in the interaction and then what the simulated patient reported immediately after the visit. To look at what those discursive frames look like, for abrupt, for example, the patient might report something like, the pharmacist wouldn't even let me finish what I was saying. And in the interaction, we would see a lot of crosstalk, cutting the patient off, being like, whatever, just have it, those kinds of things. Neutral is just pretty clinical, probably what we call standard practice. Nothing really to note. And then we had some pharmacists that were very caring. So, you know, she really considered how I was feeling. Most of the interactions were neutral. And the little bit of the controversial thing, I suppose, from this small scale study, 32 visits, is that the white actor definitely appeared to be involved in more caring interactions than the other 3. And the South Asian actor, unfortunately, appeared to be involved in most of the interactions that were abrupt in nature. So the methodology proved feasible. We seem to get a little hint of implicit bias there. We could definitely expand this to explore other demographics besides race. We chose race. In this case, it's very well documented, but there's no reason we couldn't use actors of different weights, for example, or any of those other things I mentioned earlier. And so we really need to consider, this is suggesting that implicit bias, unsurprisingly, is present in pharmacists. Everyone has it. There's no reason that because I'm in a clinical role, I'm not going to have implicit bias. So the next part of this, I suppose, is how do we address that? And I can talk to you at length about that at some other point. But certainly this is something I would love to keep working in pharmacy to explore this more. So I would like to thank the FIP Foundation for Education and Research who funded this study, and my fantastic collaborators, 3 out of 4 here at the conference, and Megan, who's over in Canada now. The full paper is published if you're super interested, so please go away and scan that QR code now. And also, if you're particularly interested, there is an implicit association test run by Harvard where you can test your own implicit bias. So if you want to take that link down, and you can choose which test you want to do. And I guarantee some of you will go into there going, I don't have these implicit sexist attitudes, and you will be surprised. It penalizes you for how long you take, so you have to do it quickly. No thinking. Thanks, everybody.
Thanks very much, Jack. I'm going to start with the most important question. Do you believe that the woman's place is in the home?
No. That's not an explicit attitude I have to clarify.
Right answer. Okay, now a serious question. So you said that you also collected some quantitative data, so maybe in that. Did you record the race of the pharmacist that was involved in the interaction?
Here's one I prepared earlier.
Primary, I promise.
So that's some of the quantitative data that we collected. I also looked to see if the race and age of the pharmacist affected any of the interactions. So I looked to see if the gender of the pharmacist and the patient were the same, if there was any difference, if the age was different, did that, nothing came out. So keeping in mind, we only had 32 visits, quite a small sample, but that is something that we explored. Yeah.
Really cool presentation. I was just wondering how you picked the pharmacies, because what if the abruptness was attributed to how busy the pharmacy was?
Yeah, absolutely. And I think that's a really good point. This is my honours student from last year asking me a question. The audacity. That's a good training. That's a really good question, Renu. And that is a reason it would be great to have a larger sample. So the duration didn't really seem to impact the tone too much either, but certainly the busyness of the pharmacy, if anyone here is practicing community pharmacy, we're all aware that the quality of care we can offer is very different when I've got 50 scripts waiting in the dispensary to check versus if it's very quiet. Generally speaking, pharmacies follow a standard pattern of busyness. So we did hope that by visiting at approximately the same time, the busyness of the pharmacy would be the same. Some people try to classify the busyness as how long you have to wait to speak to the pharmacist or how many people were in the pharmacy. That wasn't data that we captured, and perhaps that's something that we could have to account for that. Yeah.
Got a tough one for you, Jack. As you know, we're redesigning our new degree, and it'd probably be good to train our pharmacists and not have this implicit bias. Do you think we should do that early in the degree or later in the degree? Where do you think we get the most benefit?
It's complex. So you can't necessarily train someone out of their implicit bias per se. We all have it. It's going to be different. So I've lived in Australia my entire life. I'm a white cis male. That's going to affect my implicit biases. And it takes a lot to try and untrain that out of someone. It's a shortcut that our brain has, and that has benefits as well as these drawbacks. In terms of trying to train people out of it, exposure and getting people to reflect on their own biases is really one of the few things that we have to help combat it. I don't see why we couldn't start that early on. The challenge is that they're also context specific. So it's one thing to get our students to think about it in first year sitting in a tute room versus if we have them in a community pharmacy, these biases manifest differently based on the environment that we're in. So I think it's not, let's section it off in one tutorial of women doing cultural competence in first year. It's something that we need to be aware of continuously. And that's for all diversity and equity and inclusion aspects. We've got to stop funneling it into just one tiny area. It should be woven into the entire curriculum.
I can see that there's a few people listening online. Is there any questions online from any of the online participants? You're welcome to unmute and ask. If you're talking, we can't hear you.
Anyone out there?
That's that say on second. Going to take that as a minute. Any more questions from the floor here? Thank you very much, Jack.
I'll let you all scan that while we set up. Do I have Fackle or Fackle?
Oh no. Dispute.
Yes. So good afternoon.
I'll introduce you first.
Okay. Sorry.
No, it's okay.
Enthusiasm is always good. So I'd like to introduce Mr. Fatul Moon, who's a last year postgraduate student and the Master of Pharmaceutical Management program at Universitas Gadjah Mada in Indonesia. He's going to be presenting his work, Compliance as Community Pharmacists with COVID-19 Health Protocols. Could you please make him welcome?
Thank you for the time. I'm sorry, I'm very nervous here. My name is Fatul Moin. I'm from Universitas Gadjah Mada in Yogyakarta. And now I want to present my research result in my master program in regarding community pharmacist compliance to COVID-19 health protocols in the special region of Yogyakarta, Indonesia, supervised by Dr. Anna and Professor Yayi. As all we know, the COVID-19 pandemic started in Wuhan, China, when one case reported in December 2019. 3 months later, in Indonesia, 2 cases confirmed from the government, and until the end of June 2022, there are more than 6 million confirmed cases and more than 100,000 dead cases in Indonesia. And after that, the World Health Organization declared the COVID-19 virus as a global pandemic. At first, the COVID-19 attacked the elderly, but now the COVID-19 attacked all the age group. And of course, the health workers as the frontliner who handle the COVID-19 patient. And surprisingly, more than 2,000 health workers died, and 48 of them are pharmacists. So the study aimed to determine the compliance level of community pharmacists to the COVID-19 health protocols and to identify its correlation to the level of knowledge, organizational environment, and self-efficacy factor. The method of this study located in the special region of Yogyakarta, the data collected on August till December 2021, with the inclusion criteria is the pharmacist who has registration letter and works at pharmacies with active permit certificate. The ethical consideration obtained from the Medical and Health Research Ethics Committee of Universitas Gadjah Mada. The study design of this research is a mixed method with a sequential explanatory approach started by quantitative study and followed qualitative study. In quantitative study, simple random sampling used with a minimum sample 240 samples by the Slovene formula, and the data collection consists in 2 questionnaires. The first one is compliance level questionnaire, which also the dependent variable, and the second one is the compliance factors questionnaire, consists in 3 sub questionnaire adapted from social cognitive theory by Albert Bandura. And the data analysis in quantitative study used person and sperm correlation test, while in the qualitative study, the respondent in qualitative study by purposive sampling from the respondent who have the interesting finding in the quantitative study, the data collection by in-depth interview, and the data analyzed by transcription and categorization to get the theme from the interview. The result of the quantitative study, there are 262 pharmacists in this research. With the finding is the interesting finding in the social demographic characteristic is the first one. Majority of respondents is female, and nearly half of respondents were aged 30 years old or above. And surprisingly, there are 10 unvaccinated respondents, and there are 76 respondents has been infected of COVID-19 virus. And the compliance level, the first, we used normality test to categorize the compliance level, and the data was normally distributed. So the level compliance, the compliance level categorized by the average. So in the under the bottom table showed the majority of respondents in the moderate level of compliance, followed by high level and low level compliance. In the correlation test, the three independent variable, the normally distributed data will be use a person correlation test, while the not normally distributed use a Spearman correlation test. In this finding, the organizational and environmental factor and self-efficacy factor have a significant correlation to the compliance level, while the knowledge factor, there are no correlation to the compliance level of to the COVID-19 health protocols. In the qualitative study, we collect 9 respondents who have interested finding in the quantitative study, for example, who have high compliance or low level compliance. And the most of respondent in qualitative study was female. And the finding, the short finding is as you see in the slide. The first is the implementation of health protocols was lesser at now than when there was an increase in COVID-19 cases. The second, the role of the government is only advice and appeal, and the inspections from the government are very rare. The third, community pharmacists admitted that they reminded each other if they did not comply with the health protocol. And the last one is no punishment was given for those who did not comply to the health protocol. So the conclusion of this research, the compliance level to COVID-19 health protocols of the community pharmacists in the special region of Yogyakarta, mostly in the moderate categories. And the second, there is a relationship between organizational and environmental, and also self-efficacy factors that affect to the compliance level of community pharmacists in implementing the COVID-19 health protocol. So our suggestion from this study is the pharmacy management needs to monitor and advise all employees, including community pharmacists or pharmacy assistants, regarding the importance of implementing health protocols according to the producer. Even though the number of COVID-19 cases in Indonesia was decreased, but we don't know what will happen in the next time. And the second one, the government needs to monitor and enforce inspection of the pharmacies, not only to giving advice, but to look. But the government must look what is happen in the pharmacy. So I think that's all. Thank you for your attention.
You didn't need to be nervous. That was a lovely presentation. I really missed it, sorry, because I was having a few bits of paper there I need to be looking at. How did you actually measure compliance? Because it was on a score of 1 to 40. So how did you score compliance?
Yes, the compliance level, we use a Likert scale questionnaire consisting of the health protocols we adapted from the standard operational procedure from the Ministry of Health. For example, I use a mask, maintain physical distancing minimum 2 meters, do the disinfect the pharmacy twice a day, and like that. We adopted from the minister SOP.
And then the Likert
and then the Likert scale,
yes. And they reported doing those things, or how much they agreed with those things?
Yes, the grade is 1 till 5. The lower is the lower score is 1, 2, 3, but mostly have a high compliance, but not. But the community pharmacists do not do that. Do not do the SOP every time. It's only it's very rare. Even that as you see the knowledge factor is there are no correlation, because they are health workers, so their knowledge mostly in high categories. So there are no correlation, but it's about the habitual of person when they do not comply to the health protocol, when there are no supervisor from the top level management of the pharmacy.
Just because they know what to do doesn't mean they necessarily do it. you have any other questions? No, you've done a good presentation when no one has any questions.
Oh.
One more? Thanks.
I'm curious about your thoughts on how compliance may have changed over the course of the pandemic. So I would say in Australia right now, we're probably, not everyone's wearing a mask, for example. So we're getting quite complacent as time goes on, I suppose. And I'm curious to hear your thoughts on if you think that's happening in Indonesia as well.
Excuse me.
So if you did the survey at different time
Yes,
points,
different time.
do you think the level of compliance would be different?
Of course, it will be different because after I do this research, I go to the Department of Health in Yogyakarta I told them that you must to to do inspection to the pharmacy. So I think there are different results if this research do it at this time.
Thank you.
So the department, the ministry has taken on board your findings and acted on them?
No, it's self-finding.
So they know that they don't necessarily act much like pharmacy.
Yeah.
Okay, thank you so much, Basil.
Yes.
So the last speaker in this session is Susie Welch. Susie is a senior pharmacist in research at St Vincent's Hospital here in Sydney. And I see that after many years of watching you present at SHBA conferences, you're finally coming over to the dark side and you're a PhD candidate here at the University of Sydney. Congratulations. Please welcome Susie and her presentation, Connecting the Dots of Care, Linking Aboriginal and Torres Strait Islander people with Diabetes Care in Hospital using hospital pharmacies. Thanks, Susie.
Just before I begin, I'd just like to acknowledge the traditional custodians of the land which we meet today, the Gadigal people, and pay my respects to elders past and present, extend that respect to Aboriginal people here today. So thank you. Thank you. So for the benefit of our international listeners today, I'd just like to have a bit of background that an estimated 370 million Indigenous people live worldwide on every inhabited continent. Of these, approximately 880,000 are Aboriginal and Torres Strait Islander people, and this represents 3.4% of the Australian population. They live across all states and territories, from metropolitan to rural and remote areas, and prior to colonisation, they were thriving. And despite 200 years of being treated with policy practices based on a deficit model, they are able to adapt, change, and have survived in the new world, and are still surviving today and are present and contributing to community. This is testament to their strength. The Aboriginal and Torres Strait Islander concept of health is not just about the individual person, but a whole of life view that includes the social, emotional, and cultural well-being of the community. And their well-being is strongly connected to country law and community. This connection from these as a result of colonisation has had negative effects on their quality of life and health. And together with the social determinants of health, this has resulted in health disparity. Often Aboriginal and Torres Strait Islander people don't know they have diabetes or they're at risk of getting diabetes. Despite this, in the recent health survey, 8% of Aboriginal and Torres Strait Islander adults self-reported to have diabetes. And diabetes was the second leading cause of death for Aboriginal and Torres Strait Islander people, with 7.2 per 1,000 hospital admissions that had diabetes as a primary diagnosis. So we know from published data that documentation of newly diagnosed diabetes and follow-up plans in the hospital discharge summaries and communication to GP is poor. With diabetes occurring from a younger age in Aboriginal people, increased screening rates are important and may contribute to earlier diagnosis and management of diabetes and hence long-term outcomes. So we wanted to do a project which had the aim to develop, implement and pilot test a pharmacist-led screening service. It had Aboriginal leadership in its co-design methodology devised by our team, including Aboriginal Health Unit. It had some governance, which also included Aboriginal Health Unit. And we had some clinical rationale for the study. We had ethics approval. The method was, setting was in a major metropolitan teaching hospital here in Sydney. The participants were Aboriginal and Torres Strait Islander people that were admitted to hospital over a 2-week period last year. Sorry, 12-week period last year. Eligibility criteria were the HbA1c was greater than 6.5% with no known diabetes, and HbA1c greater than 7% with known diabetes. And patients were recruited and identified via the hospital patient admission system and approached during their hospital stay. So the procedure that was followed was the daily admission list was reviewed by the study investigator or a hospital pharmacist, and patients were excluded if they were due for discharge, already discharged, or had other reasons. For example, they were admitted to a unit that already had metabolic screening. Patients were approached with this information graphic, and if they consented, they had their HbA1c checked. They were revisited with the result. If it was high, then they were asked a few questions and are referred to endocrinology, and they were contacted 48 hours after discharge from hospital to see how they were getting on, and they were sent a $20 store voucher in thanks for their time, and we had a feedback barbecue. So the results are that there were 190 patients identified within this time frame. 118 were excluded primarily because they were due for discharge shortly, leaving insufficient time to organise bloods and review if needed, or if they'd already been discharged by the time the investigator went to see them. 72 were included and only 5 did not consent. So of those 67 that consented, 6 of them were identified as having a high HbA1c, 5 were known to have diabetes, and 1 was not known to have diabetes, and all of those 6 were not previously known to endocrinology, and they were referred to endocrine. The other 60, 1 was invalid, but then the other 64 extra patients were found to have a HbA1c between 6 and 6.4, which is known to be pre-diabetes. In the post 48-hour follow-up phone call, just before I go on to that, 5 of the 6 patients were seen by endocrine during their stay in hospital. 1 patient was discharged before they could visit, but they knew that they had to go to the GP. So then in the follow-up phone call, we can see that 4 had already made an appointment to see their GP, 5 had made changes to help with their diabetes, and all were satisfied with the diabetes care. So what does this mean? Well, 9% of our group were referred to endocrine because they've fitted our criteria. A further 6% were identified as having pre-diabetes, and the patient and the GP were contacted to have a further discussion about optimising lifestyle. And overall 15% were identified as new, poorly controlled or high risk of having diabetes. The other benefit was that lots of yarns about diabetes happened even if people did not need referral to endocrinology, and a consent rate of 93% actually showed the importance that Aboriginal and Torres Strait Islander people put on health and wellbeing. So preliminary analysis has shown that hospital pharmacists can detect if Aboriginal and Torres Strait Islander people in hospital who have poorly controlled or newly diagnosed diabetes or previously unknown to endocrinology. The strengths being the high response rate, co-design process, and the fact that we identified people. There were limitations, it was a pilot, and also we found that we need to maximise the time going forward for referral to and for endocrine review. So whether that's minimising the time to HbA1c or increasing the number of pharmacists involved. I'd just like to acknowledge the funding that I received to do this project through the Applied Medical Research and Inclusive Health Fund at St Vincent's Hospital, and my supervisors and collaborators, Pauline DeWeerd and Scott Daly through the Aboriginal Health Unit, and Professor Alex Fido, the endocrinologist at St Vincent's. Thanks very much.
Thanks very much, Susie. I'll start. So In the hospital setting, obviously nurses do a lot of screening at admission and at various points during the admission. What made you choose to go with a pharmacist-led model here rather than integrating this with the existing nursing screening?
That's right. I think, you know, anyone can do this screening. It doesn't have to be a pharmacist. I also happen to be a pharmacist. And my initial thoughts was, well, what can pharmacists actually do to assist to perhaps hopefully close the gap in some way for the health and the health disparity. And so we cottoned on to this idea that actually pharmacists, similar to nursing staff, we see patients every day. And so often are looking at results as well. And so if they can have an impact on that clinical disease state and help the patient in that way, then that's why I focused on. Yeah.
Thanks, Susan. I was just interested in what happens when you're closing the gap when people leave hospital. I just didn't quite get through your presentation. Was there a standard method of communication to the GP with the results so that the GP was aware of what had happened in hospital?
Sorry, I must have missed saying that, sorry. So yes, in the once the pharmacist had seen the patient, we then added in the results into the electronic discharge summary that went to the GP. The plan from the endocrinology department, when they reviewed the patient, they would then add their plan into the electronic discharge summary, and that would be communicated to the GP. So thanks for asking that.
Are hospital pharmacists able to order blood tests in your setting?
I don't. In theory, we can possibly not. I add on blood tests all the time, particularly surrounding therapeutic monitoring. But however, this is more than a blood test. So this is an actual relationship between the patient and their body. And so adding on a blood test is the final part of that communication with the patient and an understanding surrounding diabetes. And it's their body. And so actually their test can only be done really after discussion with them. So we have thought about automating that HbA1c add-on thing. And actually on speaking to community and people that work in the diabetes field in Aboriginal communities, that's really not a great way forward. The better way forward is to talk to the person and lean an understanding. And that's where all those yarns were fantastic, to be honest, because more people then know about diabetes. To be honest, Aboriginal people know about diabetes. And there's a lot of shame for many Aboriginal people surrounding chronic disease. And that's where rocking up to someone with a blood result is not the way to address the problem, not being the problem being the person, but the problem being diabetes. And so I think that communication is most important. Yeah.
Were there any questions from anyone online? Just the silent talking person.
Anyone there?
Okay, we might wrap up, and thanks, Susie, very much. Thank you. Now, I don't know how many of you were in the poster session earlier, but you would have seen that about half of us are addicted to our mobile phones. But I think the fact that there was very little mobile phone usage during the session is a real testament to our speakers, to their interesting and diverse topics and the way that they presented their research. So can I please ask you to join me in a round of applause for all our speakers? So thank you very much for joining us for this session. We're now at afternoon tea, which will be across the corridor in the common room. Thank you for your interest. Thank you for your questions, and have a good afternoon. Thank you. Thank you very much. Yeah.
I think I've definitely done it all. Firstly, thanks for sharing as well. That was great.